Center.
Thank you.
Dr. Noinika Bose. Dr. Noinika Bose.
Good morning, everyone. I'm Dr. Noinika Bose, and I will be presenting my paper today on the predictive value of retinal nerve fiber layer thickness for postoperative visual improvement in patients with pituitary macroadenoma. As we all know, pituitary macroadenomas are of importance as they compress the chiasma and cause visual defects. Reliable and consistent predictions of visual outcome for surgical decompression of pituitary macroadenomas are difficult. Although RNFL thickness has been studied before, no defined cutoff has been defined, and the lack of a well-defined cutoff for RNFL makes it difficult to counsel patients regarding visual outcomes. Our study attempts to evaluate the predictive value of RNFL thickness for improvement in visual fields and visual acuity in postoperative patients of pituitary macroadenoma. The study adds a reasonable objective cutoff for preoperative RNFL thickness that can predict postoperative improvement in visual field. It can also help in research and daily practice by preoperative counseling of patients to be done objectively. It was a prospective observational study conducted at a tertiary care hospital of Eastern India. Patients were selected for 3 months from January to March and followed up for a duration of 1 year. Preoperative and postoperative visual examinations were done, and ROC curves were constructed for RNFL values to define the ideal cutoff value of predicted improvement. The cases selected underwent MRI and were planned for endonasal endoscopic excision. A complete ophthalmological evaluation was done. Patients with papilledema, glaucoma, high myopia, extensive retinal pathology, and on treatment with cabergoline or prior pituitary surgery, radiation therapy were excluded. Those who underwent greater than 90% tumor resection were selected for the study. Preoperative tumor volume was calculated from contrast-enhanced MRI of the brain using the Cavalieri's principle. Ophthalmological assessment was done for visual acuity by Snell's chart under optimal lighting conditions and recorded in logMAR units. Visual field was analyzed in the HFA 32- program CETA standard, and visual field effect was assessed from mean deviation in decibels and visual field index in percentage. OCT RNFL was done preoperatively. The postoperative visual outcome was done in the 2 to 4 months follow-up period after the surgery. Improvement in visual acuity was defined as any improvement from the baseline. Visual field was documented as improved if there was improvement in mean deviation by 5 decibels or visual field index improvement by at least 10%. Analysis was performed. The table 1 shows the demographic and clinical profile of the patient. 29 patients were selected with mean age of 43.9 years and most were male. The preoperative visual function showed that the major complaint was a decrease in vision in 72.4% patients, and the most common field defect on HFA was temporal hemianopia. All eyes with total disc pallor and had a reduction in visual acuity, and all eyes with any disc pallor, temporal total, had some form of visual field defect. Table 2 shows that in our patients, the mean preoperative RNFL thickness was 89.02 micrometer, and the RNFL in different quadrants was significantly thinner in eyes with visual dysfunction and disc pallor. The mean follow-up period was 10 months, and table 3 shows a significant postoperative change in visual acuity, mean deviation, and visual field index. The rate of postoperative improvement for visual acuity was 75%, that of visual field effect was 61.9%. Table 4 shows a various analysis of the prognostic variables with respect to 32 eyes with visual acuity defect and 42 eyes with visual field defect. It is seen that with respect to visual field defect, eyes that improved had significantly better preoperative visual acuity, thicker RNFL, and smaller tumor volumes. The table 5 shows a logistic regression analysis of prognostic variables, which shows that RNFL thickness remains significantly associated with improvement in visual field effect. The average RNFL thickness of 81 micrometer predicted an improvement in visual field effect with 73.1% sensitivity and 62.5% specificity. Predicting visual outcome following surgery for pituitary microadenomas are difficult. Deterioration of vision can occur during intraoperative, postoperative complications, which are unpredictable. Montre et al. Conducted a study using the macular thickness with macular RNFL and ganglion cell layer to correlate with visual field loss. In our study, we used the peripapillary RNFL thickness. Compared to Danish Mayer et al. Study, the eye shows improvement in visual acuity in our study, 75%, and there was no significant difference in RNFL thickness between those who had improvement in acuity and those who did not. Our study demonstrated an odds ratio of about 1.1 for improvement in visual field effect for 1 micrometer of mean RNFL thickness. Principal strength of the study was that it was prospective. Limitations of the study was that follow-up period was variable. Postoperative visual fields may have been better in literate patients. The sample size was not too large, and we did not study the ganglion cell layer complex. So it can be concluded that preoperative average RNFL thickness of greater than 81 micrometers can be used as an objective predictor. These are my references. Thank you.
Thank you, Dr. Noinika.